So our next speaker this morning is Dr. Ole Gredal from Denmark, who's going to be talking to us about changing the practice for end-of-life care for MND ALS patients. Welcome.
I would like to thank the organizers and the chairman for giving me the opportunity to speak today. The title of my speech appears on the first slide, Gathering of Knowledge with a View to Change the Practice of End-of-Life Care for ALS Patients, focusing, among other things, on support for their relatives. Just a minute. Yeah. Yes. This shows the organization of ALS care in Denmark. The Rehabilitation Center in the corner, left corner down, is the center I come from. It's a national rehabilitation center for neuromuscular diseases, and we can, together with the GP and home health nurse palliative team, we can follow the patient closely with home visit, with meetings and so on. Others, such as ALS teams in the Department of Neurology and Respiratory Centers, see the patient 2 to 3 months intervals, while hospice and local partners see the patient when they have relevant problems. In addition to the medical professionals, there is also the Danish patient organization, Muskelsvindfonden, who take care of the more political and health political things in Denmark. The Rehabilitation Center is a key player in the coordination of joint ALS care between patient, hospital, and local professionals. And we provide counseling to the patient and their family through the entire course of the disease. Practically all ALS patients in Denmark are referred to the Rehabilitation Center, and this is about 130 per year. Here is a list of the different professions represented by the Rehabilitation Center ALS team and what we do. We have a nurse, 2 nurses, a social worker, occupational therapist, neurologist, as I am, and a psychiatrist. And what do? We visit the patient in their homes, draw up rehabilitation plans. We teach and supervise home health nurses in the patient's home. We arrange meetings and seminars for the patient and their relatives. And we regularly meet with the hospital ALS team and the respiratory centers. In 2011, we carried out a study to examine what happens to the patient during the terminal phase of ALS and how we can improve our work. For example, where did the patient die, and was it the place they preferred to die? Were deaths unexpected or expected for the relatives? And how many of the patients were using feeding type, non-invasive ventilation or ventilator at the time of death? And for how long time they use it. We also wanted to find out which type of medication were prescribed during the terminal phase, how satisfied the relatives were with the care provided, and what the relatives thought about the counseling offered after the death of their relative. The objective of the study was to answer the above-mentioned questions. We began with a short pilot period and then a project period which ran from February 2011 and 1 year to the end of January 2011. The patients we examined were all ALS patients who were referred to our center and died during this period. When we became aware that a patient had died, we wrote a letter to the relatives informing them that we would contact them by telephone 2 to 3 weeks later. If they agreed to participate, we carried out a telephone interview with a relative based on a structured questionnaire and asked our collaborative partners for information, for instance, from patient records. The results show that 120 patients died during the year, 53% men, 47% women, in the age range from 43 to 97 years, and a mean age of 68 years. 68% of the patients were married or cohabiting. We only succeeded in getting responses from 63 relatives out of 120 patients who died. This is 53%. The slide shows how we collected information from other sources. For example, from Department of Neurology, 19%, home health nurses, and GP, 8%, and wider on. As for our results, I will primarily concentrate on the 63 relatives, or 53%, we obtained responses from. Of those, 49% died at home, 22% died at a neurology department, 8% at a nursing home, and only 10% at a hospice. According to the relatives, 60% of the patient died at the place they and the patient had agreed on. We asked the relatives whether the death came expected or unexpected, and 37% answered that this was unexpected, whereas 5% said death had occurred as a planned termination on either non-invasive or invasive ventilator treatment. Um, 75 patients, it's all of 120, all of them, that is 63, were using a feeding type at the time of death and were using it for an average of 370 days, say nearly a little bit more than a year. As for how long the patient were using the time, we found out that 5% had a tube for less than 10 days, 12% for less than a month, and 20% for less than 2 months. And this is not so good, I think, but here we might think that the patient have their autonomy to decide what they want, and it also what the doctor told them what to do. This shows how many patients were on life supported, such as non-invasive ventilation or invasive ventilation. 17% were on non-invasive and 13% on invasive ventilation. On average, 15.2 months for non-invasive and a little bit more for than 2 years for those on invasive ventilation. This means that some 30% of all Danish ALS patients who died in 2011 were on life support with respiratory treatment. And I think the number is increasing a little bit at the moment. This shows a variety of patient symptoms that were reported by the relatives. Anxiety seems to be a serious problem with nearly 60%. The same goes for air hunger. Also, mucus build-up, pain, and sleeping problems seems to be a serious problem, as shown by a high percentages. This slide shows the type of medication prescribed during the last 2 to 3 weeks. The relatives said that morphine were prescribed in 65% of the cases and benzodiazepines in 40% of the cases. And then the other, which you can see in the table, oxygen, antidepressant, and mucolytic drug, and so on. Unfortunately, we don't know about the doses prescribed, neither for morphine or benzodiazepines. Here we see what the relatives replied when asked whether they were satisfied with the care provided. For instance, from a home health nurse, with 56% said they were. They were satisfied, and not satisfied is only 5%, don't know 19%, and not relevant for 13%. From the table, it appears that the palliative team and hospice were not relevant for a large portion of the patient. Many were satisfied with a GP and with the ALS team in the Department of Neurology. On this slide, we see that the services of the Rehabilitation Center were not relevant for many of the patients in the terminal phase, whereas the Rehabilitation Center was used in 62% of the cases. Many of the relatives did not find any use of a psychologist or a priest during the terminal phase. The total responses shows that approximately 60% of the relatives were satisfied and used the palliative care for the relatives during the terminal phase. After the interview, which many of them were on telephone, I can remember one of our nurses told that one of the relatives came to her office, and it took more than 2 hours to make the interview and hear the story about the situation the last 2-3 weeks. But after this interview, approximately 1 in 4 to 5 said they would like to receive further counseling, whereas many of them said they would not know until later. And I think the interview is a good thing, because we had to contact the relatives and ask if they had questions. And then we, in this study, got information about what they think we could do better. Conclusion: to sum up, 49% of the relatives said that the patient died in their own home, and only 10% died in a hospice. In 37% of the cases, the death came unexpected to the relatives, and 60% of the patient died at the place they had preferred. The conclusion is that it seems difficult for the patient and the relatives to cope with the disease during the terminal phase. I have 2 more conclusions. Over 60% were using a feeding type, and 30% of the Danish patients were on life support in form of non-invasive or invasive ventilator treatment. 65% were taking morphine and 40% benzodiazepine, and according to the relative, over 50% of the patients were suffering from anxiety and air hunger during the terminal phase of the disease. In general, 60% of the relatives have used and were satisfied with the palliative care, and only 1 in 4 to 5 wanted further guidance and support after the death, and this interview we made. On the basis of these figures, we have concluded that satisfactory care plans for the terminal phase are not yet successfully implemented in Denmark, and that a closer collaboration with GP, palliative teams, and hospice are recommended. If there are questions which I won't have time to answer now, we will also be present at the poster session at poster number 161, where we'll be happy to answer your question. Thank you for your attention. I will finish my talk with this picture, and it's said from one of the more successfully stories about ventilator treatment in Denmark. Biver has been on have ALS 14 years, and he has been in invasive ventilation for more than 12 years. Thank you.
Thank you, Ole. Okay, we do have time for questions. So again, perhaps when you ask your question, could you give your name and where you're from, please? But do we have questions in the room? Okay. Yeah, here's the first one. If you could wait for the microphone, please.
Hi, I'm Lisa Bardak from ALS of Michigan. Thanks for your data, fantastic information. I'm curious what your definition of expected and unexpected death was.
Yes, it's a little bit difficult because we just asked the relatives, have you planned in the near future that your ALS patient are going to die? That was the way we asked. But of course, it's difficult, and it can also be difficult for a professional to tell the patient how many days, how many months, how good are your respiration, what are going to happen. It can be very difficult. I have discussed a lot with our respiratory center how we can do it better in this way. And you have to have measurement, I think. You have to measure the vital force capacity or the carbon dioxide retention if you should make a good to tell the patient what's going to happen. But it's a big problem, I think.
Okay, we have a further question here.
My name's Patricia. I'm with the ALS team at University of Virginia. The patients who go on ventilation, do they stay at home? Whether it's non-invasive or the invasive ventilator, are they at home on that?
I couldn't hear it because of the helicopter up here.
Yeah, really loud. So I think your question was patients that are on ventilation, are they on ventilation at home or do they stay in the hospital?
Okay, yes, okay. In Denmark, we have a social system where it's possible for the patient to stay in their own home and have the treatment. And for example, Biver, which you see here on the picture, his wife is working as a nurse in the Department of Cardiology, and he has, I think, 6 or 7 helpers during the 24 hours a day. And he has a very active life, making films and so on. It would not have been possible if he had stayed in a hospital. So in Denmark, we have a special system, and it's also quite expensive, I must tell you. Such helpers for Biver, for example, or for some of the other patients, cost, let us say, about $300,000 per year, I think it is about. So it's quite a lot.
Okay, further question at the back.
Yes, hello. My name is Charles and I'm from the Western Pennsylvania ALS chapter. And when you had the data up there about individuals who died at home and on hospice, were the ones on hospice, were they at a facility, and was there individuals who died at home that had home hospice?
Only very few patients die at hospital, and that's because in Denmark it have not until now the hospice has only been for cancer patients, but it's changing now, I think, and it's possible for them to go and have at the moment in many of the hospice to go for maybe 1 or 2 weeks, and the hospice then make a plan for the optimizing the treatment in air hunger and anxiety and so on. And then they go back in their own home, and when the time for the death is coming, or they choose to go to hospice, then they will be there. I hope that was the answer.
Okay, and one final question at the back.
Yes, actually I have a question and then a comment. I'm also, thank you for an outstanding summary and presentation. Concerned about the 67% figure that hospice and palliative care was, quote, not relevant, because as most of us in the room feel, that's pretty much the cornerstone and a vital part of end-of-life care for ALS patients. My comment has to do about the unpredictability of death. There was a study several years ago of patients with metastatic terminal lung cancer. And in this case, physicians were unable to predict accurately when the patient died. For example, the patient died within 3 or 4 days of being seen by the physician. In fact, their prognosis 2 to 3 days before death was actually 3 months of expected life. So we know across the board professionals have an extremely difficult time to predict time of death. But getting back to the hospice palliative care, and I should mention in terms of the states, the vast majority of hospice care in this country is provided at home or in a nursing home. Only occasionally does a patient go to a freestanding physical hospice facility, so there's a fundamental difference in how hospice care is provided across the globe. So, thank you.
I agree with you. The home is the best place to be if it's possible. If the relatives and the other person have the experience and medication to do that.
Okay, thank you. So join with me again, please, in thanking Ollie for his presentation. Thank you.